Hi, I'm Frank Spear. I want to welcome you to this lesson. What we're going to talk about in this lesson is the type of patient that could benefit from an occlusal appliance. And so we're going to walk through a clinical examination of the patient over this lesson and the next one, where we actually do videos of the muscle exam, and then you'll also see videos of the joint exam. And so at the end of the day, it's all about learning who benefits from an occlusal appliance, and that's going to lead us into further lessons in this series on what type of appliances are available, how do we make the decision of what type of an appliance. But as I said, we're actually going to just start with, so who benefits from an occlusal appliance? The patient I'm going to show you actually was my dental assistant for about 16 years. Her name is Kathy. When these photos and videos were done, she was around 50 years of age. She really has no history of any joint problems. She does have a history of headaches. Before these videos were filmed, 3 days before they were filmed, she woke up, and when she went to bite down, her teeth on the left side didn't touch. And when she would try and squeeze, it was really uncomfortable for her, very painful. If you asked her on a scale of 0 to 10, 10 being the worst pain imaginable, how bad the pain was, she would actually say it was an 11. It was excruciating. If you ask her where the pain is, she would put her finger right in front of her ear on the left side, right over her jaw joint. So what I did, and it's sort of my cocktail I make for patients who have acute events, acute occlusal events, if you will, is I give them an aqualizer, because you can just pull them out of a refrigerator. You don't have to make anything. So an aqualizer being an appliance that sits on the posterior teeth. They're little fluid-filled bags, and they're connected by a tube. So it's kind of a self-equilibrating appliance. I put her on non-steroidal anti-inflammatories, typically about 400 milligrams every 6 hours. And then I put her on Flexeril, which is a muscle relaxant. So as of today, which is 3 days following the event, at least these videos were shot 3 days following the event, she can start to feel the teeth touch on the left side, but she's still uncomfortable. So what I'm going to do is I'm going to walk you through the examination. As I said, there's a lot of different types of appliances. There's a lot of different reasons we make appliances, and we'll go through those in other lessons. But the kind of classic patient we think about for occlusal appliance therapy in terms of really benefiting them is a patient who might present to us with muscle pain in particular. So let's talk a little bit about her inability to bite on the teeth on the left side. There are many things that could cause that, but a very common cause of a patient not being able to bite on the posterior teeth is actually hyperactivity of the lateral pterygoid muscle. It would not be uncommon to see that after somebody, for example, was out playing basketball and took an elbow to the chin, might have been driving the condyle back into the joint, and the body's response, because the joint's hurting and may become inflamed, is the pterygoid contracts and pulls the mandible forward, and you can't bite on your back teeth. You also could be having those same symptoms from a painful joint itself, from an actual intracapsular joint problem. And then sometimes, and this may be the case with Kathy, because she didn't have a traumatic event, we're going to examine her joints later, but she's never had a history of joint problems. This might have just occurred from hyperactive, excessive clenching and grinding during the night, because this is something she woke up with. So the acute management, as I said, for these types of situations, an aqualizer, because it's sitting there in your refrigerator, you don't have to make it, you don't have to take impressions, you don't have to do anything, you just grab it and show them how to wear it. Non-steroidal anti-inflammatories, 400 milligrams every 6 hours. And the Flexeril, I typically prefer 10 milligrams before bed, but for some patients, people wake up a little groggy, and so what I do is tell them that if they wake up groggy with 10 milligrams, cut it in half and just take 5. So in Kathy's case, the pain is coming down, and we happen to be having an occlusion workshop when this was all going on, and so I'm going to actually do this examination in front of some students, because it's often beneficial if you want to teach somebody how to do the exam. It's better to do it on a patient that has symptoms typically than one that doesn't. So if we just look at Kathy's teeth, they're actually quite nice. She has a very nice smile. The teeth are reasonably well aligned, a little crowding in the lower anteriors, but overall a very nice dentition. Probably the only thing that's unusual, if you look closely, is she has perforated through the gold crown on the upper left second molar. The opposing second molar also has some wear on it, but other than the older restoration, she's doing quite well. So when we start in on an examination of a patient, I start with a muscle exam. And in this lesson, I'm really just going to review primarily the temporalis, masseter, and medial pterygoid muscles. But in truth, in the exam, I actually go through trapezius, sternocleidomastoid, digastrics as well. And as again, you can see from the photos, nothing real obvious. So as I go through the exam with the patient, particularly as I go through the muscle examination, muscle palpation, what I keep at the chair is this flip chart. And it's a flip chart that was done by Janet Travell. Janet Travell mapped the human body in terms of trigger points. So she identified where the muscle was that was the source of the problem, but then where the person actually felt the pain. And it literally goes from the top of your head all the way to your toes. And it will show you along the way the black X's being the source and the red being where the pain is perceived. And I keep it handy for patients because it's very nice to be able to say, well, I know this is where it feels like it's hurting, but that doesn't necessarily mean that's where the actual problem is. We're going to walk through Kathy's examination. I'm going to actually play the videos so you'll see and hear me talking to the students that are watching. And we're going to start with temporalis palpation. I start in the anterior and work my way to the posterior, and it's just a gentle using my fingertips. And if we look at what Janet Travell found, is the temporalis muscle in terms of if it is painful, where does the pain get felt? It's over the muscle itself, above the eye on the side that the temporalis is uncomfortable, and also the maxillary teeth on that side. So temporalis muscles can actually perceive dental pain.
Bye.
So as I said, we'll just play the video, and then when the video is done, I'll sort of tell you my narrative on what I start to think about as it's going through. So we'll just start with temporalis palpation, and I honestly, I haven't examined Kath for a year and a half, so I don't know what we'll find. So nothing.
Well, I can. They're not real sore, but yeah, they're tense.
Are they?
More on this side.
So just start paying attention to where she keeps pointing. So left side, was it up in here? Yeah. I can actually feel it. I can feel the, and on a 0 to 10, how tender?
Maybe 3.
Okay, so what I was doing is I was moving just with a gentle palpation from the anterior back to the posterior, and there literally is, it feels like a little frozen pea almost, where the muscle is knotted up on her left temporalis, and that's the area that she's saying is uncomfortable. Now, I want you to realize she said it's a 3 out of 10, but this is following 3 days of appliance therapy, 3 days of nonsteroidal anti-inflammatories, and 3 days of muscle relaxant. So you can imagine, had we tried to do this exam the morning that she woke up and couldn't close, our pain levels would be significantly higher. And what I'm looking for in the muscle exam is literally discomfort. Do I feel these little nodulated areas, and are there areas that are uncomfortable to the patient? Because frequently, that is the kind of patient where an occlusal appliance will be very beneficial for them in terms of getting them more comfortable. Following the temporalis, I'm going to move down to the masseter. And again, if we look at the masseter and where the masseter produces pain, really you have the superficial masseter and you have the deep masseter. The superficial masseter actually, again, refers pain to posterior teeth. It also refers pain above the eye on the side that it's down. It also refers pain right in front of the body of the muscle. The deep masseter refers pain right into the area around the ear. And so as we go through this, what you would notice is that there are multiple muscles that actually refer pain right over the joint or to the areas surrounding the ear. So when a patient comes into you and they say, it hurts here, and they put their finger in front of their ear over the joint, the natural assumption would be it must be the joint itself, But oftentimes that's not the case. Oftentimes it's actually a muscle that's producing the discomfort. Now what you're going to see in this video is when I go to do the masseter exam, the other muscle we're going to examine in a minute is the medial pterygoid, which is on the internal portion of the angle of the mandible. And if you have a patient that's relatively thin, like Kathy is, you actually can palpate the medial pterygoid inside the angle of the mandible. And I'll show where that would be at the start of the video, but in truth it's much easier to do it intraorally. And then the other thing we're going to do in this video is after I palpate the muscles, we're going to have her open and close. And masseter is an interesting muscle in that it contracts when the posterior teeth come together. So that as she's closing, the masseter really doesn't contract firmly until the posterior teeth touch. And a very simple test to evaluate whether somebody's touching both sides at the same time is to ask them to open and close and feel with your fingers whether both masseters contract at the same time. If they don't, if one contracts obviously earlier than the other, what it tells you is they're hitting one side much sooner than they are the other side. So again, we'll just play the video and you can follow along. Now, on cath, you can actually get inside the angle of the mandible. On a lot of people you can't, and that's where medial pterygoid is, but that's also where parotid is, so sometimes you're not sure quite what you're palpating here. So we'll move up to the masseter and we'll do the medial pterygoid intraorally. How's that?
A little tender.
And again, 0 to 10.
About 3.
Okay, left temporalis 3, left masseter 3, left digastric 2, sternocleidomastoid 3, everything going on so far here. Not real high levels, but not asymptomatic. How about the right side?
I mean, it's a little tender, maybe a lot.
Okay. Now, while we're doing this, I'm going to have her open wide and slowly close and clench. Do that one more time. Close and clench. And what I'm trying to do is see if the two masseters contract simultaneously. And I'm also trying to get a sense for how big are the masseters. I want you to do it one more time for me. Close and clench. Again. Okay, now I may be, they're close, but I'm sensing the right one fires a hair before the left one. Now that may be that I'm reading into that. Often when you start seeing elevator muscles that are tender, it's on the side that doesn't touch first. Now when we do check for point of initial contact, that may not be true. But what happens is when one side doesn't touch first, the elevators have to work to bring the teeth together on that side, if the other side hits. And it's close, but my right finger seemed to be, and I don't know if you have a sense for one side hitting sooner than the, yeah. Do you have a sense if one does or not?
Mm-hmm.
Which side hits first, do you think?
I think it looks
Right and then left, yeah. And that's, in cath, you can actually feel this little boom, 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 boom. And that would actually fit her history of the last few days, because in fact 3 days ago she wasn't able to bite on the left side. It's just today that she's actually even started to touch lightly on that left side. So the other muscle that I want to demonstrate in this exam is medial pterygoid. We're also going to talk about lateral pterygoid, but I'm going to actually evaluate lateral pterygoid during the joint exam, which will be our next lesson. When we talk about medial pterygoid, it's actually a fairly easy muscle to palpate. You just have to think about the point that you would normally give an inferior alveolar injection and where you would insert the needle for the injection. If you just were to let your finger go distal, you'd be slipping right into the medial pterygoid muscle. And where does it refer pain? Again, right over the joint, right in front of the ear. So if you have a hot medial pterygoid, it's easy to be mistaken and think that in fact it's a temporomandibular joint issue. Now, what I want you to watch in this video is as I slide my finger into that position where I can press on the muscle, I want you to watch her eyes and see what happens when she experiences the discomfort of the pressure. So there's my injection site. I just let my finger go right inside that. There's medial pterygoid. Tender. And on a 0 to 10.
Probably about 4.
Okay. And a 4 on left medial pterygoid.
Well, that is a little tender, like a 2.
And so what you start to see with Kathy is we've got a temporalis that's got some discomfort, a masseter's got some discomfort, medial pterygoid's got discomfort. That's the kind of patient that, to me, I think about starting to choose an occlusal appliance to see if I can help them. Now, as I said, in later lessons, we're going to walk through all the different kinds of occlusal appliances, but somebody with muscle pain like this, typically they benefit from the correct occlusal appliance. As I mentioned, lateral pterygoid, we're going to evaluate in the next lesson. If you wonder where does lateral pterygoid refer pain, again, right in front of the ear and right under the eye. The superficial belly of the lateral pterygoid refers pain under the eye. The inferior belly of the lateral pterygoid refers pain in front of the ear. And the lateral pterygoid being the muscle that's responsible for moving the mandible, moving the condyle down and forward during translation. So essentially what I wanted you to see in this first lesson is sort of what it looks like to do a muscle exam in a patient that's having discomfort, the palpation that we use, and then what I do is rate it on a 0 to 10 level, 10 being the worst pain they can imagine, 0 being they don't have any sense of discomfort at all. In Kathy, even after 3 days of anti-inflammatories and an aqualizer and muscle relaxant, she still has, on a level of 3 or 4, almost every muscle on the left side. The question, of course, is really the muscle the only thing that's the problem with her, because she points right over her left joint. So in the next lesson, we're going to go through the joint examination. So I look forward to seeing you then.